sepsis and shock. Okay, this is something, I mean, who's seen a patient with sepsis? Probably everyone in this room, right? Very, very common in oncologic patients. Objectives are going to be the same kind of objectives as with Janice's lecture. So we'll talk about patho with every single one. We'll talk about signs and symptoms, risk factors, treatment, how to manage these emergencies, all right? So sepsis, the basic patho behind sepsis, we all know, right? This is very basic stuff. But just remember that we have some sort of pathogen that's going to invade our body, right? It's going to be a bacteria, fungus, whatever. And what happens next? You guys teach me, you know this. What does the body do in response? Immune system freaks out a little bit, right? It's going to host or mount that immune system response. And what's going to happen in the vasculature at that point? Inflammation. Inflammation. What else? What happens to our vessels? They get leaky. That's very, very important. What else? What happens to the diameter of the vessel? It dilates, right? So the blood pressure is going to go down, as we all know. The heart rate goes up, etc. Also, we get this massive release of inflammatory mediators systemically, right? And then as a result from that, we're going to start having a lot of perfusion issues to a lot of our major organs in the body, heart, lungs, brain, etc. We'll see tissue hypoxia, then that's going to lead to just massive cellular dysfunction. And then cell death, really, right? So when we look at sepsis, this is the reason why patients die of sepsis, is because they can go down this trajectory very quickly. Patients will start to have MODS, or multiple organ dysfunction, right? We all know that term. Multiple organs are dysfunctioning, right? Dysfunctioning, is that a word? I don't know. They're dysfunctional. And this leads to very diffuse cell injury and cell death, right? So you're not just seeing it in one area of the body, you're seeing it all over. That's leading to compromised organ function in all of these areas, right? So you might have a patient that shows confusion, right? That's a sign. But that could also be a sign of lots of other things. So we have to start investigating. They might have a hard time breathing, cardiovascular shock, they're not peeing as often, liver failure, et cetera, et cetera. Leodell mentioned capillary leak, right? Those vessels start to get very leaky. So we are not only dilating the vessel and losing our blood pressure and our resistance that way, but we're also losing volume into the interstitial space through those leaky vessels, right? Okay, questions on that? This is what we consider multiple organ failure, where we see all of these things listed across the bottom, and this is why patients die of sepsis. Okay, remember that. So again, looking at this trajectory, we start with systemic inflammatory response syndrome, or SIRS. You guys have all heard that, right? Familiar terms here. SIRS is the definition, is listed here. This is where you're going to see two or more of the following. Their temperature is going to be either very high or very low. You guys ever seen that in a patient? It's not as common, but it can happen, right? Hypothermic. Respiratory rate is above 20, heart rate above 90, and then their white count might be very low, or it could be high, right? So when you see two or more of the following, we can of those things, we can consider that SIRS. Moving down this little timeline, we're going to move to sepsis. Sepsis is defined as having 2 out of 4, at least, of these criteria, plus a suspected or confirmed infection in the body, right? So it's the same stuff, just now we have a potential reason, right? A potential source of infection or a confirmed infection, okay? Next is we're going to see severe sepsis. And this is when we're going to have everything that we just talked about, so sepsis, plus now we're seeing signs of end organ damage. So that perfusion is, or lack of perfusion is actually starting to affect those organ systems, and we're going to start seeing problems systemically throughout the body. You're also going to see a low blood pressure, systolically less than 90, and their lactate level is going to bump up. Usually above 2.2 is the criteria we consider for severe sepsis, all right? Okay, next we're going to see septic shock, right? Not something we want to ever see in a patient, but our patients can get here pretty quickly, unfortunately. To consider yourself in septic shock, you have to have everything we just talked about up to here, so severe sepsis criteria, but now this patient is going to have persistent low blood pressure, no matter what you're doing IV fluid-wise, right? So you're giving IV fluid resuscitation to this patient, and they're having consistent low blood pressures, despite your intervention, all right? Why is that? Why are they having low blood pressure still?
It's just leaking out.
It's leaking out, right? It's not even staying in the intravascular space. And that diameter of the vessel is not constricting. There's not enough resistance in there, right? Good. You're also seeing those signs of end organ damage, which is what we just saw across the bottom of that one slide. And then the lactate is typically about 4 at this point. Is 4 a high number for lactate? I mean, where's that on like the spectrum? You guys remember? Medium.
Is it above 7?
Right, yeah, it's a high number for lactate, right? We definitely don't want it at that point. It can get much higher. Well, I want you to remember this number because we're going to look at mortality rates associated with lactate levels in a couple slides, and so we'll come back to that, okay? Questions on this? All right. So early recognition is so important with sepsis, right? Sometimes we call it the silent killer because it's not always something you can see, like superior campus syndrome, where you have this giant head, right? I mean, it's not as easy to look for and to see on the outside. So we have to always be asking ourselves, does our patient have abnormal vital signs? Do they have those clinical manifestations of sepsis? Do they have any of those signs of end organ damage, right? Constantly doing a really good assessment. Does my patient have an existing infection? Do I already know? Is this already confirmed? Or do they just have a possible infection? Do they have a central line? That puts them at risk right there, right? Do they have some sort of wound or drain or something else that could put them at risk? But more importantly, do they have abnormal vital signs? One thing I want you to always remember, especially when talking about OCN, is that tachycardia and low blood pressure are 2 main signs of sepsis, right? They're things that we see all the time, but tachycardia will always come before hypotension, right? Hypotension is more a late sign than tachycardia. So when you start to see a hypotensive patient, just know that they're already in trouble, right? They're already moving down that spectrum very quickly, okay? Here's a list of risk factors for sepsis. Stuff that we know. These patients are typically very young or very old. That puts them at risk. They might have compromised skin integrity. They might have invasive devices like a central line or a Foley, whatever. They also have potentially a chronic illness and poor overall health. And this paints a picture to me of what? What type of patient? All of our patients, right? Lawyer's like, every patient I see on the floor. This is every patient we take care of in oncology hospital because of this, right? Every patient that has an inherent cancer diagnosis is put at risk because of everything that comes along with cancer diagnosis. But what's interesting is cancer gives you a whole other list of risk factors. So not only do you have everything else we just talked about, you're also going to have potential neutropenia. You guys know what that is, right? Someone want to volunteer the definition for us? Low neutrophil count, which means what? No immune system, no ability to fight off infection. So when we have a neutropenic patient, that's actually the most important risk factor for sepsis in a cancer patient. And the longer their neutropenia, so the duration, is going to increase their risk for sepsis exponentially, right? We can see patients that are neutropenic for how long? What's the longest anyone has ever seen?
Very long.
Month?
Yeah.
A couple months, right, we're saying? Yeah. It depends on their treatment.
They may not work as well as we know.
What about a patient that goes for a stem cell transplant that doesn't ever engraft? Right? They're in trouble because their immune system hasn't come back to protect them. They're going to be neutropenic for a really long time. Those patients are at very, very high risk for infection. So watch for that. The second thing that cancer gives you as a risk factor is sometimes the actual malignancy or the actual cancer can cause immunosuppression. A lot of our hematological disorders, right? Leukemias and lymphomas, things like that. Anything that's going to affect the bone marrow or the CSF or the spinal column or spinal cord, anything like that, could potentially cause you to have immunosuppression just inherently from the cancer. The other thing is the treatment that we give these patients, right? We give patients chemotherapy. Does that cause immunosuppression? Yeah, almost all cancer or all chemos do that, right? Chemotherapy, we give radiation, we give patients steroids, and then, heaven forbid, we give them the big atomic bomb of a stem cell transplant. We completely myeloablate their bone marrow. They have no immune system. So this puts them at huge risk for sepsis. All right, those are just a few. We won't cover them all. Questions on that? Okay, this is easy stuff, right? Signs and symptoms of sepsis, we break this down between early and late signs. And we know these because we're all very intelligent nurses. But what I want you to look here and notice is within these early signs, tell me which ones of these are telling you that the body is trying to compensate for something. Tachycardia, breathing quickly, right? Tachypnea, what else? So you could argue like all of them are, but these specifically, right, are telling you that the body is trying to compensate for something, right? So compensatory mechanisms are starting to show. Within our late signs, which ones of these are telling you that, okay, the body's compensating, but now those compensatory mechanisms are being completely overwhelmed? Hypotension. Yeah, I mean, it's all of them, right? The reason these are late signs is because the body is not able to compensate anymore, and that's what late signs are. Is there a sign that the body's compensatory mechanisms are being overwhelmed, basically, right? And this is where you get the organ damage, right? And the other thing I want to point out here on this slide is what's the number one thing listed under late signs? Hypertension, right? So interesting, as a new nurse, I always thought like, sepsis classic signs are low blood pressure, high heart rate, fever, all those things. And as soon as I saw low blood pressure, I'm like, oh, and now you start thinking about sepsis. But actually that is a late sign, right? So that means that this patient is already in a little bit of trouble. And they've probably already started to move down that timeline, okay? Remember that. All right, so quite a few years ago now, nationwide, they had what's known as the Surviving Sepsis Campaign. Anyone heard of that? This is something that actually started our Muse protocol here in this hospital. So I was on the original Muse committee, and I remember going to all those meetings. All we talked about was these bundles of interventions, right? These bundles are what our Muse protocol was born from. So you'll notice that these are very similar to what we have in this hospital. But nationwide, they came up with a 3-hour sepsis bundle and a 6-hour sepsis bundle, all right? And these are things and interventions that need to be completed within 3 hours or 6 hours from time of presentation with sepsis. So within 3 hours, the patient needs to have their lactate measured, number one, blood cultures drawn, antibiotics given, and then fluids, right? Those are the main things. Don't worry too much about the details. Within 6 hours, we could start vasopressors, right, for low blood pressure that's resistant to IV fluid resuscitation. We're going to be monitoring their central venous pressure and lots of different other things. It's mostly in an ICU setting. And then we're going to be doing serial levels of lactate over and over again, right? And why do we do that? Trying to see that lactate. We want to see it coming down, so we're looking for our trends, right? If we see it going up, well, what do we know? What we're doing is not working, right? That's why we're doing serial levels over and over again. It's how often is it on the Muse protocols? 4 hours? That's what I thought. So every 4 hours you're drawing the same lab, which sometimes feels repetitive, but it's because we're watching for that level to come down so that we know what our interventions are doing and if they're working. These are the lab indicators with sepsis. These are things you're going to see. These are not actual numbers because that's not as important as knowing the trends, right? So obviously increased lactate is what you would see. Blood cultures could potentially be positive. They might not be. White count could be increased. It says if possible, right? Sometimes do patients not have a white count at all and they're completely septic? Yeah. Our patient's immune system is a little funky. It doesn't always act in the way that you would think it would, right, in a traditional patient. Glucose levels increase initially, so sometimes they will spike up and then sort of level off. BUN, creatinine, LFTs, and then our clotting factors, all of those are going to be increased or prolonged, right? Which makes sense. We know this stuff. All right, questions on that? Okay. Whoops. Okay. Nursing interventions, very simple. We're going to make sure that this patient has IV access, right? ONS says an 18 gauge preferred. A lot of our patients have central lines, which is great, but sometimes we're using every line within the central line, so they've got to have multiple peripheral lines placed. Make sure they have adequate access. Apply supplemental oxygen, watching their glucose levels, watching for DIC, which is something that we'll talk about today, watching for signs of fluid overload, and then watching for those potential sites of infection. Pretty cut and dry, right? Okay. Why is obtaining a lactate so important? What does lactate measure? And why do we have to get it number one on the list? It tells us about cell death. Good. That's an easy way to describe it, right? So lactate really does give us information about cellular hypoxia or cellular death and what extent we have with cellular death. Remember I said we were going to have that mortality rate. So It's interesting, with the lactate level of 2.5, your mortality rate is less than 5%, right? But when you get up to greater than 4, your mortality rate jumps up to 27%. There was a case we looked at in the Muse committee meetings in the beginning. There was a patient who had a lactate of 14 that was not adequately intervened upon. That patient passed away in our HICU like 2 days later. And that was a huge reason why our physicians were like, we need this protocol, right? Because people just were not paying attention like they should to lactate levels. And actually, that's one of the reasons why it's number 1 on the Muse protocol. That patient's mortality rate was probably like, I don't even know, way, way, way high, right? So know that it exponentially grows as you get higher, but anything above 4 is very deadly for our patients. And then you think about a patient that doesn't have an immune system to fight off infection, right? And that's even scarier. And this just tells us why we do those serial levels, which we already talked about, right? Helps us to know what we're doing is working. Okay, questions on that section? Mesa?
So there's been a few providers that I've interacted with lately who don't feel like lactate is a really like end all be all number. And I think that through the last couple of years with classes like this, we've learned that it's a big deal.
Yeah.
Is there like another one if they're like, I don't want to get another lactate? Is there something else that we could say like, what if we got this? So like, is there anything else that's similar to a lactic acid?
I mean,
I think lactate is like one of the
Part
more.
of the
advanced.
protocol. There's like a protocol.
And it's one of the more acute signs. So you
I mean,
can
of
see-
course, our patients have so many complex things going on that maybe they don't feel like the lactate is the catch-all for this, but it is part of the protocol, and so as the nurse, we should always be advocating for like, let's do the protocol, because that's what is required of us. I do know that there are some physicians who push back on that a little bit, right? And it's just a matter of getting them on board and getting their buy-in with this protocol, but this is a nurse-driven protocol. This is separate from like ONS and OCNR. This is hospital, like Huntsman-specific stuff, but it's a nurse-driven protocol that you should be able to initiate. And if they're giving you pushback, I don't know, do you guys have any ideas about something else you could draw? I can't.
just draw it again.
Yeah.
I don't
That's
even ask
the
them.
nice thing- That's the nice thing for like where we work because
Right.
it is a nurse-driven protocol.
Yeah.
But like there are people who I've talked with from outside hospitals, just about kind of what we've been doing, and they're like, well, I think lactate's not a good like basis to go off of. You know, if we have liver involvement, it doesn't. And then they give me all these things, and I'm like, well, what else do you recommend? And they
I
can't
don't
really
have a
give
good
me
answer for you, I'm sorry.
No, it's fine.
But it's a real thing, right? We're experiencing that a little bit, and I know Huntsman 5 originally, like the surgeons did not understand why they needed to draw lactate on all these patients, because they're like, my patient just went through this massive surgery. That's why their vital signs are all funky. That's why they have all these things. I don't need to draw a lactate, right? It took a little while to get them on board, and now do you feel like they're better about it?
I fight them all the time.
You? Yeah, I feel like the times for Huntsman 5 have definitely dramatically decreased, but it's still an issue, right? It's just having that conversation with your provider. This is a driven protocol from the nurses. We're gonna go ahead and do this. If you wanna add extra things on that, go right ahead, you know?
Yeah, and that's what we usually tell the doctors, all of us pretty much as a unified front, if this is within our protocol, it's within our power to order this, and it's actually our hospital policy, so.
It's more like we're notifying them than
Yes.
asking them.
Yeah.
Exactly.
Well, that's great. If anyone can think of something else, let us know. Okay, let's talk about DIC. This is another one that sometimes people have a hard time wrapping their head around, right? I'm gonna try to make this as simple as possible. So, overview of DIC. This is a definition that comes from the literature. It says that DIC is characterized by inappropriate and exaggerated overstimulation of normal coagulation in which thrombosis and then bleeding occurs, right? Those are the two main points. Thrombosis or clotting and bleeding, which seems super weird. How in the world do you have clotting and bleeding at the same time, right? Doesn't make sense to me sometimes. When you really look at it, it makes sense. So, again, lots of details up here. Don't worry so much about the details. Think about the basic concepts. And that's really the basic concept. You have bleeding and clotting at the same time. And we'll go over why. These are our coagulation pathways or clotting cascades, right? We have two pathways. We have our intrinsic and extrinsic pathways. What you want to point out here is this number. Factor 3 or tissue factor is very important in oncology nursing. Do you guys know what tissue factor is? Anyone? It's a protein that's found on the surface of a lot of our cells, especially in some of our highly vascularized organs, right? And it's actually what initiates that extrinsic pathway, okay? So when you have tissue factor and it initiates this extrinsic pathway, you're gonna meet the intrinsic pathway at this common point right here, which is factor 10. And when factor 10 gets initiated or activated, you're gonna start moving down that common pathway, which is here, right? And what does this lead us to? A clot or clotting, right? Good, does that make sense? Pretty easy. All right, that's all I want you to remember from that. All this other stuff. Tissue factor, like I said, is this glycoprotein that's found on the surface of a lot of our cells, but specifically in a lot of our highly vascularized organs, like all of these beautiful pictures here. It can also be found on the outside of circulating blood cells, things like platelets, macrophages, neutrophils, etc. Okay, and it can be cleaved off of the edge of a cell and released into the vascular system as well. But what I want you to remember is that tumor cells or cancer cells have the ability to actually produce tissue factor. This is one of the biggest reasons why our oncology patients are at such high risk for DIC, is because their cancer cells can make tissue factor. Freaky, right? Cancer cells can make whatever they want, and one main thing they make is tissue factor. Tissue factor, like I said, is expressed on the surface of those tumor cells. But tumor cells also have the ability to create or produce these two other things, cancer procoagulant and plasminogen activator. And the main points are listed underneath here. Cancer procoagulant actually activates factor 10. Remember, that's that common point where the intrinsic and extrinsic meet. So if cancer procoagulant can activate factor 10, again, putting that patient at risk for going down the clotting cascade, okay? Leading to a lot of clotting, but then also bleeding, which is what we'll see. With plasminogen activator, this is a component of the fibrinolytic system, okay? This also, because it's part of that system, is gonna lead to clotting and then bleeding, right? Okay, we all got that? All right. Okay. All right, so like I said, this seems like a paradox, right? Seems a little weird, but what might help you remember this is actually within the former term for this disorder. You guys remember what DIC used to be called? I don't know if you remember, I didn't know this, but so it used to be called consumptive coagulopathy. And I think that makes sense. Why didn't we just keep that, right? Consumptive coagulopathy. We're consuming our clotting factors. And with consuming all of our clotting factors, we're going down the road of bleeding, right? So we start with clotting a lot of times, and then that results in bleeding, okay? And we're gonna look at the reasons why. So at the top, you guys see three things. There's massive cell death, endotoxin, and endothelial injury. One of the main reasons why our patients go down the road of DIC is gram-negative sepsis, right? Or some sort of gram-negative infection. When you have a gram-negative infection, this is gonna release what's known as endotoxin. Endotoxin is something that is commonly involved with DIC. Once you have that released, it's gonna activate that clotting cascade, right? Other reasons why you might go down the road of DIC is massive cell death, like sepsis, which is what we just looked at, right? And any kind of endothelial injury, right? Where would you potentially see endothelial injury? What'd you say?
Snake bites?
Snake bite, for sure. Yeah, no, it's true. These are a lot of reasons, right? So all of these things down here could be because of, could be leading to these things, right? So yeah, snake bite, but even just something as simple as surgery could cause endothelial injury. Trauma, there's other things, frostbite, blood transfusion reaction. That's why some patients go to DIC with that, etc. Burns is a big one, but obviously we highlighted cancer. That's a huge reason, right? Cancer can cause all of these things up here. And when we have DIC, it's always considered a secondary diagnosis, okay? You'll notice that all of these things up here are primary diagnoses, but DIC is always gonna be a secondary diagnosis to usually their cancer, right? Okay, important to remember. So, like I said, for one reason or another, whether that's the endotoxin, the cell death, or the endothelial injury, we're gonna have tissue factor release, which is what we saw in that clotting cascade, right? Bear with me on this. This has a lot of arrows. Some of you remember this from past lectures. Just hold on to your seatbelt, right? So tissue factor is released. With tissue factor, this is triggering that clotting cascade, right? Watch these little animations because we're gonna have to go through this kind of stuff. All right, because of that, because we're going down the clotting cascade, we're having diffuse clot formation, right? We're going down all those different factors. So lots of little mini microclots are being formed. Because of that, we're gonna have ischemic cell injury diffuse all over, right? You're gonna start seeing lack of oxygen and perfusion to different parts of the body because of all those little mini microclots. You with me? That could lead to massive cell death, right? And right back to more tissue factor being released and right back to more clots being formed. So we're going around in the circle at this point. More clots and more damage and more endothelial injury, right? And more cell death. This is going to lead to something that you don't need to worry too much about. This is microangiopathic hemolytic anemia. And this is where those little red blood cells that are trying to go through the vessels that are now narrowing because of all the little mini microclots, those red blood cells are lysing and we have hemolytic anemia from that. And that is going to lead to more tissue factor being released and again, going in the circle, okay? More and more clots, more and more damage, more and more tissue factor, back and forth. With endothelial injury from this, we're also having platelets starting to form and aggregate and clump to form clots, right? More clots. This leads to consumption of clotting factors and platelets, right? So because of everything we just went over, basically what I want you to remember is lots of clots being formed. We have that negative feedback loop where we have more tissue factor being produced and more clots being formed and more damage, right? Back and forth. This is consuming all of our clotting factors. So now because of that, we have bleeding. We good on that? Okay, that's the basis of DIC in a nutshell. But what else we also have to go over really quick is this. So this, don't worry so much about this. What this is telling you is that because of all those clots forming, plasmin is being activated. You have fibrin trying to break down clots, because that's a normal process in the body, right? Your clots are trying to be broken down all the time. When you break down clots, you have fibrin degradation products, or FDPs, being released, which can also start to inhibit platelets being formed and clumped, and that leads to bleeding. I mean, don't worry too much about those details. Just remember, clots being formed, your clotting factors are being consumed because of all the mini microclots, which leads to bleeding. It's the basic stuff. Okay? We good on that? Okay, I'm gonna go forward. All right. So, clinical presentation. We have symptoms in two main categories. We have symptoms that are related to ischemia because of the clotting, and we have symptoms related to hemorrhage, right, with the bleeding. These are things that you could potentially see in a patient with DIC. Who knows what purpura fulminans is? You've never seen that? I asked Janice if she'd seen it. She said like once or twice, but I've never seen it. I had to Google this one, an image. This is where we have a thrombotic disorder that manifests in all these little blood spots all over the skin. Massive bruising and discoloration of the skin resulting from coagulation in small blood vessels within the skin, which rapidly leads to skin necrosis. So sad. It looked awful. It looked very, very, very painful for a patient. So that's what that is. But it makes sense, right? You're having these little mini microclots and all those blood vessels in your skin right up to the surface. And you're having ischemia, and that's going to lead to your cells starting to die, your skin dying. So you're going to have gangrene. Acrocyanosis, which is just that kind of dusky blue color in the skin. You might start to see infarcts in other parts of the body. So you might have them in your heart, in your kidneys, in the renal cortex in your kidney. You might have it in your brain, in your intestine, like all over the place, right? And these are not as easily to be seen, I don't think. I also don't think they're as common. With hemorrhage, these are more apparent, right? You're going to see that petechiae bruising all over the skin, that little mini micro bruising, which when I first saw it, I thought it was a rash on a patient because it kind of looks like a rash, right? But it is very mini micro bruises. Ecchymosis, you might have oozing sites. A central line might start to bleed. A patient might have a nosebleed. You could have vaginal bleeding, rectal bleeding. I've seen bleeding from the eyes and from the ears. Sometimes I've seen bleeding from just like the pores in their skin, right? And that's very severe DIC. Bleeding in the urine, a GI bleed might have blood in the stool, etc. We know what this looks like, right? But these are the two main things. Okay, I want you guys to tell me what the labs are going to look like for this patient, right? When we have a patient in DIC, what happens to their platelet count? We don't have to know numbers, these are trends. Down. Perfect. What about our clotting times? PT, PTT. They're prolonged, right? Good. It's taking a longer time to clot because all those clotting factors are being consumed. Oh, forgot that one. Okay, what about the rest? Plasma fibrinogen, our FDPs. Yeah, reduce. FDPs go up, right? Because we're going to have all those clots being broken apart, and FDPs are being released into the system. Do you remember that part? And then our D-dimer is going to be up as well, right? That goes along with our FDPs. Good job. So again, with all the oncoemergency that Janice covered, first we have to treat the underlying disorder in order to effectively treat DIC. And that can be very tricky because what is our underlying disorder almost always? The cancer, right? So if the only cure to treating this is the underlying cause, that's really tricky because we can't always cure their cancer. So for that reason, these patients will have repetitive oncoemergencies. They will repeat over and over and over again. DIC is something that we see a lot in cancer patients. Who's had a patient with that? A lot of us, right? Okay. So treatment, we're going to give blood product transfusions, which makes sense, but why are we specifically giving platelets to a patient? We're replacing their clotting factors. I think that's what I heard you say, right? Okay, good. Oh, whoops. Why are we giving FFP? Do you guys know what FFP even is? I can't hear you guys. What'd you say?
The clotting factors.
It's clotting factors, exactly. We're just replenishing their clotting factors. That's really all FFP is. And then why are we giving PRBCs? Because they're bleeding, right? So we're good. It all makes sense. But the one I always get a little confused about is cryo or cryoprecipitate. I always wonder, why the heck am I giving like 15 bags of this cryo, right? But cryo also contains a ton of clotting factors, right? So that's really all you need to remember. It's the cold insoluble portion of FFP, right? And when FFP is thawed in a refrigerator, then this is what is going to precipitate, which is interesting. It's considered a blood component. It contains clotting factor proteins, and it has all of these, 150 to 250 mils of fibrinogen. It has von Willebrand's factor, it has factor 13, factor 8, etc. Right? Very important stuff that we would need to be replenishing in this patient's body because everything is being consumed.
Wouldn't this just lead to more clotting?
I would hope not. I don't know. I see your point. I don't think so.
What's the question?
If giving these back could just contribute more clotting.
Because you're just.
I mean, there's potential for that, yeah. But I think that once, because really we're trying to prevent the bleeding, right? Goodbye, Gia. Yeah, I mean, obviously there's other things we're gonna have to do, but I see your point. Because if the body has more, they're just gonna start using more, is that what you're saying?
Yeah.
Yeah, no, it makes sense.
And then you're gonna end up with more clot.
Yeah. Let's hope that that doesn't happen. I don't think it does. We also give heparin to patients in DIC, which to me seems really bizarre, right? But if you really look at it, it makes sense. So we give heparin because heparin does not break down clots or break up clots. It's actually just going to prevent this patient from going further in the clotting cascade, right? So that's why we give heparin. But actually heparin is not given as often as it used to be for patients in DIC. It's only recommended for patients that have active clots that are causing a big problem, right? Or the primary reason for the DIC. Typically patients you'll see that are more in the bleeding realm than the clotting. Patients that are in the primary phase of clotting, you might see them have heparin administered. Questions on that? Okay. We're providing supportive care to these patients. Of course, monitoring vital signs and watching the hemodynamic status, taking oxygen, etc. Watching their neuro status because of all those potential infarcts, right? Asking them those neurological questions. Who's the president? That's a bad question to ask these days. But we have to ask questions like that because we have to assess what their neuro status is. We also have to institute bleeding precautions, right? This is very basic for us because we have patients that have myelosuppression. And when they have no immune system, they have no platelets, and they have no red cells, we do these things all the time, but these also help with patients with DIC. You don't want to put tape on their skin, because when you rip it off, what's going to happen? Potential for bruising and bleeding, right? No electric, you want to use electric razors, not like the big, horrible razors that can cut you. We tell patients to use SpongeBob toothbrushes and soft bristle ones, right? Because we wouldn't want them to cause any damage further in their gums that could lead to bleeding. All of these things, right? Wound assessments. These little things are supposed to be like Sennas or something. Bowel protocol. But why would we need a patient on a bowel regimen? Seems weird. So they don't have a brain bleed. But how does that work? Straining, right? So if a patient's constipated, right? Because of who knows what, pain meds, chemo, vincristine, who knows? They're constipated and they're going to strain to have a bowel movement. What's that going to do in the brain? That Janice just talked about. Increase ICP. As soon as you have increased ICP and a patient with DIC, that's no bueno, right? No platelets, etc. It's a very a bad combination, right? Because you're going to lead to potential brain bleed. All right, we know this stuff. SIADH is our next section. So questions on what we just talked about. All right, we gotta whip through this stuff. So SIADH, sometimes you can have too much of a good thing, right? Charlie and the Chocolate Factory, you guys seen that movie? I've never seen it, so we're not gonna talk about it because I don't understand the movie. But basically, you can have too much of a good thing, like wine and chocolate and attention and all these things. What do we have too much of in SIADH? Antidiuretic hormone, right? I think that sometimes it gets confusing because people say, well, it's a syndrome of inappropriate ADH, but how is it inappropriate? Is it inappropriately high or inappropriately low, right? It is an inappropriately elevated ADH. Just remember that. That's really all you need to remember about SIADH. We'll talk about a little bit about why. So what does ADH do in the body? It helps hold on to water, right? Good, Aubrey. So ADH is basically vasopressin, right? That's something that we give for patients in our ICU. And vasopressin actually means blood vessel, or vaso means blood vessel, and then pressin means to squeeze. So when you're giving a patient vasopressin, what is it going to do to the smooth muscle in our arterial vessels? What's going to do? It's going to constrict, right? When you have vasoconstriction, that's obviously going to result in increased resistance in that vascular space. And that's going to lead to an increased blood pressure, right? Okay. Also, ADH can target the kidneys. And within the kidneys, well, all I want you to pay attention to is this, really. Within our distal tubules and collecting ducts, we have upregulation of our aquaporin channels due to ADH. So when you have an increase of ADH in the body, do you guys remember aquaporin little doors? People are shaking their heads. All right. So basically, within here, you're going to have these little doors that can swing open and swing closed. Those are called aquaporin channels. And when ADH is present here, especially in an abundance, these aquaporin channels or doors are going to swing open and they're going to stay open. And what that's going to do is it's going to allow the body to now reabsorb more water back into the vascular space or wherever it needs to go, right? So upregulation of aquaporin channels and upregulation of water retention, right? More water, we're holding on to more water. Why would we need to hold on to more water? What are some reasons why the body might start to secrete more ADH? Sodium levels? Yeah, because we would want to maybe dilute out some sodium. Yeah,
When we dehydrate.
when we're dehydrated, that's a huge one in oncology, right? When our patients are dehydrated, they need more vascular fluid volume, right? So we would need to have more resistance there. Good. So what causes ADH to release? These, I don't know if these will ever be on the test, but basically in your aortic arch right here, you're going to have what's known as baroreceptors. You guys remember that from anatomy and physiology and stuff, right? So baroreceptors are in the aortic arch and also in the carotid sinus, and they are going to recognize in the body when this patient is going to have a low blood pressure. When it senses a low blood pressure, it's going to send a signal up to where ADH is released, which is posterior pituitary, correct? I don't want to tell you wrong. Yes. And it's going to cause that to release more ADH. More ADH comes in the body, we start retaining more water, and we're getting a higher blood volume and blood pressure. right? So that's one reason. You also have osmoreceptors in the brain that are also going to sense when blood osmolarity is too high, right? Or the blood is too thick, it's too viscous. And so when we have that sensed, it's going to cause more ADH to release. We retain more water, we dilute out our blood volume, right? It's not as viscous and thick, okay? Other things, when we sense a low blood volume, there's nerve endings in the heart that can start to cause the body to retain more water. And then also this RAS activation. You guys remember the renin, angiotensin, aldosterone system, right? So specifically angiotensin 2 can cause the body to release more ADH. Don't worry too much about that. That's a good FYI. All right, so what happens with a moderate yet inappropriate increase of ADH? We're gonna take, I think her name's Violet. We're gonna take Violet and we're gonna look at her for a minute. So this is the normal state of Violet. When she has normal amounts of ADH, she has this much water and this much salt, right? In proportion. A little more water than a little more salt and a little less salt. But when we have an increase of ADH, she has this much water and this much salt, right? Okay, hang with me here. So when, look forward. You would think that she would look like this after a while, right? But actually this doesn't happen all the time. So, or at least not yet, because the body has those compensatory mechanisms, right? Do you guys remember this lecture from probably lots of other things? So when you have this high blood volume in the body because you've retained all this water, you're going to have an increased pressure on those blood vessels, right? And what that's going to do is it's going to sense, oh, I have enough volume here. So the aldosterone release will go down, or the ADH release will go down, and this is going to cause more salt to be lost through your kidneys, right? The body will start excreting. But what happens is that when we have salt being lost in the kidneys, we also have water being lost because water follows salt, right? Okay. With that, you're going to have actually a low sodium level in the body, but you're going to have euvolemia because the body has tried to compensate. So that's why they don't blow up like a balloon. But in turn, they have low sodium because of the renal losses of sodium, right? It's a lot of words trying to explain one thing. We have dilution in the body as well, right? Because of all that retention of water. So two main reasons why you have hyponatremia. This is important to remember. Because of the renal losses of sodium, but also because of the dilution in the vascular space, because of the retention of water, right? Okay. This is what their urine is going to look like. Who knows what this is? The Great Salt Lake, right? In all its glory. You are going to see a ton of salt in their urine, right? So remember the Great Salt Lake. When you have SIADH, these are some conditions that can lead to that. Stroke, hemorrhage, trauma, surgery. Those are things that we could see in a cancer patient, but a lot of times we see dehydration, right? Vomiting, diarrhea, hyperthermia, that's very common in oncology patients. Also, if you have a family history of SIADH, this could put you at risk. And sometimes just having an infection, right, can put you at risk. But there are specific medications that can alter ADH secretion in the body, and they are these. So nicotine, phenothiazine, those all stimulate ADH release. Don't worry too much about this, but what I want you to know about is this. There are specific chemotherapies that can alter ADH secretion, right? Specifically cytoxin or cyclophosphamide and cisplatin. Those two ones, right? So with these chemotherapies, we're giving aggressive hydration for these patients, right? So that all makes sense. There are other things that can alter ADH secretion. One main thing is that the actual cancer cells, just like in the other slides we saw for DIC, remember how cancer cells release tissue factor? Cancer cells can actually ectopically release ADH as well. They just decide that they want to release this hormone, and they do it, right? Because they're smart enough to do that. And one main cancer to remember that does this is small cell lung carcinoma. Okay, when you have a patient with small cell lung carcinoma, they're at risk for SIADH because of that. But these other cancers can do it as well. And primary brain tumors, you'll see this a lot as well. Okay. So, signs and symptoms. We're going to break this down between mild, moderate, and severe. And we're looking at sodium levels, right? Because that is ultimately what the emergency is about hyponatremia. So with low sodium of 125 to 134, we consider that mild SIADH. So really, you're going to start seeing anorexia. The patient might have a little bit of headache. They might be nauseated. Might throw up a little bit, fatigue. It's very vague, and it's kind of hard to say, oh, that's SIADH, right? Because do our patients ever have these things for another reason, right? It's hard. But you're going to have to tie that in with your sodium levels. But what you need to remember is when it gets over in here. So sodium between 115 and 124, you're going to start seeing that lethargy in a patient, confusion, ataxia, muscle weakness, muscle cramps, right? That's what you're seeing with low sodium. But specifically less than 115 is when we consider that severe. Anyone ever seen a patient less than 115? Yeah? On the floors. Yeah, right? So these patients should go to a higher level of care at 115, but sometimes providers will hold on to them to get a little bit lower. But they should go upstairs, or I guess downstairs from here. These patients are at high risk for other problems, right? Like coma and death. But seizures is a huge one. These patients will almost always be put on seizure precautions, and they're going to be dealing with a lot of lethargy. Their body's going to be very like diminished reflexes, basically. And we're looking at our labs to diagnose this. We're specifically looking at sodium, but also we're looking at urine studies, right? So you're going to see a decreased plasma sodium because of that dilution effect in the body, less than 135 typically. A decreased plasma osmolarity, does that make sense, right? Because you're having not as thick of a blood. Increased urine osmolarity, why is that? What do we pee out? A ton of salt, right? And then increased urine sodium because we pee out a lot of salt, but you're still having eubulimia, right? That is the criteria for diagnosing SIADH. This is stuff that we can see on labs, right? Do you guys have this in your notes? I just want to make sure I'm not going too fast. You do? Okay, great. So again, Oncologic, you have to correct that underlying disorder, which could be tricky. In some cases, it's easier said than done. Apparently in Charlie the Chocolate Factory, these people have a hard time going back to normal, right? He gets like stuck in some tube and she turns into a blueberry and I think that guy got shrunk or something. But it's just this hard in cancer too, right? It's really hard because we can't always cure their cancer. We can't always treat the underlying disorder. So we're gonna have to do the best we can in a temporary situation, and they might have this happen again and again and again. Treatment for mild hyponatremia is gonna include basically a fluid restriction, right? Because we don't want the patient to be drinking a ton of fluid and causing even more dilution in the body and even more water retention. So typically a liter a day, sometimes providers will say a liter a shift, but we sometimes will see a no free water restriction. Everyone's seen that? Okay. Daily weights, because weights show what? Very easily. Fluid balance, right? Good. We're watching their eyes and nose very closely, and their neurostatus. We're doing serial sodium levels, safety precautions. Some patients will put on seizure precautions depending on their history. And then these patients will probably just be receiving normal safety, right? But when we get into moderate hyponatremia and severe hyponatremia, that's going to change a little bit. With moderate, you're going to include all the treatment that we just talked about, but you're probably going to add a couple medications, right? One that I want you to remember is these aquaporin channel blockers, or tolvaptan is the one that I've seen. So this is, remember those aquaporin channel little doors that swing open and swing closed in the collecting ducts of the kidney. So those doors are swung open when ADH is present there, right? Because that allows all that water to retain back into the body or reabsorb. But now those aquaporin channel blockers are going to shut those doors and lock them. They're not going to allow the water to be reabsorbed. Okay? All right. Also, prepare for transfer. Doesn't always happen, but less than 120 for ONS. Okay, so severe hyponatremia, less than 115. What's different here is these patients will not be receiving normal saline. They will be getting hypertonic saline. Important to remember, okay? It's usually 3% saline, and is this ever given on the med-surg course? No, right? We only give this in a higher level of care like an ICU setting. And the reason for that is because these patients have to be monitored very, very closely. We cannot give hypertonic saline very fast at all. It actually has to be given very slowly, right? Here's all the numbers. You don't need to memorize those numbers at all. Just know that the rate has to be very slow. And the reason for that is because if we increase a patient's sodium level too quickly, it can cause what's known as central pontine myelinolysis. What is that? Demyelination of the nerves. And it's irreversible a lot of times, right? So if we increase a patient's sodium level too fast, this is what happens. And so we have to be giving this hypertonic saline very slowly, and these patients are on close monitoring because of that. Okay, we should not ever be giving that in like a regular inpatient or clinic area. Serial sodium checks is very common, usually Q4 hours or more frequent, I would assume, and then seizure precautions as well because of that neuro risk, right? All right, questions on SAADH? We're kind of cruising through this stuff, so if you guys have questions, don't hesitate raising your hand. Maybe I'm just Okay, hypercalcemia. This is another one that I think is pretty straightforward. Basically, it's abnormally high levels of calcium, right? That's not too hard to remember. Typically greater than 10.5. That's a good number to know. Most common oncologic emergency. Isn't that interesting? Anyone seen a patient with hypercalcemia? Probably everyone in this room, right? It occurs in around 20% of cancer patients. It's the number that's online, but most common. We know that in our bones, we find 95% of our calcium, right? It's found in our skeleton for the most part and in our teeth. But what's interesting is calcium is actually divided into two main sections. We have our free or ionized calcium, and then we have that bound calcium. And it's typically bound to albumin, all right? When calcium is bound to albumin, we consider that to be inactive. It's not able to be used by the body, which sucks, right? Because you need calcium. When you have free calcium, it's not bound to anything. It's in the vascular system and it's active. It's able to be utilized by the body, right? Those are two important terms to remember. Do we have patients ever with low albumin levels? For what reason? Malnutrition, right? If the patient has malnutrition, is not eating and drinking well, their albumin levels could potentially be low. How would that impact our calcium?
The serum and calcium higher.
Yeah, good job, Erin. So basically, there's not as much albumin to bind to, so there's more calcium available in the serum, and that's going to increase our calcium levels, right? Okay, we know calcium is involved in all of these things: muscle contraction, nerve impulse, hormone secretion, etc. So the patho behind hypercalcemia in an oncology patient is basically calcium is being mobilized from the bone into circulation. That's the very basic definition. It happens in around 20 to 25% of cancer patients. Breast and lung, again, are the most common cancers that you'll see this, and specifically squamous cell of the lung. And then this is a marker for increased mortality. It's important to remember that when a patient has hypercalcemia, they're automatically at a higher risk for mortality. Okay, interesting. Yeah. There's two different reasons why patients have hypercalcemia with cancer. These aren't very important to memorize, but you have humoral hypercalcemia malignancy, and then you have local osteolytic hypercalcemia, all right? Basically, with humoral hypercalcemia, this is most often when a patient has little to no bone mets, right? But the reason behind this is that tumors start to release what's known as parathyroid hormone-related hormone. It's a weird name. PTHrP, and this results in increased renal and bone resorption of calcium, right? So it's not related to a bone met or a bone cancer or metastases, right? Again, most associated with squamous cell carcinoma of the lung, and then head and neck cancers, actually. What you want to remember is this local osteolytic hypercalcemia, or LOH. This is most commonly what you'll see for patients. It accounts for about 20% of hypercalcemia cases in malignancy. And this is where the actual bone malignancy or bone metastasis or bone cancer is going to cause hypercalcemia, right? So when you have a bone malignancy, it's going to start damaging that bone. And because of that, it's going to release cytokines, and those cytokines will promote reabsorption of calcium back into the bone. So again, leading to hypercalcemia. Multiple myeloma patients will see this: breast, lung, prostate, okay? Risk factors for this, obviously patients with bone mets are at higher risk, right? If they have a lung cancer, breast cancer, that's always the answer, but esophageal, head and neck, a lot of our hematological cancers like leukemia and lymphoma. And then patients that have hormone manipulation, right? A lot of our breast cancer patients that get that estrogen replacement or tamoxifen or whatever it is, and when we're manipulating hormone, whether we're blocking it or we're increasing it, those patients are at risk as well. And then when patients have low albumin levels, like we talked about, patients that have malnutrition for one reason or another are going to have more calcium in the serum because there's not as much albumin to bind to become inactive or not utilized by the body, right? Okay. So other contributing factors. Immobility is actually one of the main ones. Why is that, do you think? What happens when we don't move? It's related to calcium. You guys know? Or what happens when we do move? What happens when I get up and exercise? What does calcium do? Yeah, so calcium is actually brought back into the bones and strengthened them. And that's something that mobility promotes. When we have immobility, there's not as much calcium being reabsorbed into the bone. Dehydration puts these patients at risk, advanced age. When a patient's on TPN, or delicious steak dinner in a bag, right? That could put them at risk because this is full of a whole bunch of electrolytes, etc., but calcium's one of them. And then patients that take a lot of antacids, right? That's another risk factor as well. So gosh dang it, Janice told you to have them take Tums, and now I'm telling you not to, right? So another thing that's just kind of an FYI that you don't need to worry too much about, but is the calculation for getting a corrected serum calcium. So remember we talked about the difference between free ionized calcium and then bound calcium to albumin. So sometimes when a patient might have a calcium level, you'll hear a provider say, well, what's their corrected calcium, right, for their albumin or for their nutrition status? And I remember being asked that one time, I was like, how am I supposed to know that? Like, I have no idea. There is a calculation for this, and this is what it is. Basically, let me pull this up here. Just get it up there. Okay. When you have a serum calcium of 10.4, we need to correct that for their albumin. So you take this calculation, you have 10.4, and then you have plus 0.8, and then you plug in your albumin level, which is going to be 2.3. Don't worry about all the math here, but basically that rounds up to 11.8. So it's actually higher, right, based and considering their albumin. Makes sense. Okay, just an FYI. All right. All right, we're going to look through some of this. What do I want to point out here? So again, mild, moderate, and severe, but severe levels of calcium are greater than 13.5, and this is when we would consider hypercalcemia and onc-emergency. Remember that. And patients that have low albumin levels, secondary to poor nutrition, are at risk, are at highest risk. Okay. Early signs and symptoms are these. Patients will start to get nauseous and have vomiting, constipation, bone pain, which makes sense. And these are often so general and non-specific that it might be hard to tell that this is even related to their treatment or their cancer or hypercalcemia. So when a calcium level gets above 12, that's where you're going to see more specific symptoms. And the ones before are very non-specific, so it's harder, right? But things are starting to slow down for patients that have high calcium, which makes sense. And we have to remember to correct for albumin. That's the general concept to take away from that. Late signs are acute renal failure. They start to have arrhythmias. You might see heart block or shortened QT. Wave changes. It could get as bad as cardiac arrest. We've seen a patient with a pathologic fracture because of their cancer, right? Because of all that damage that bone met is causing to the bone, that it just has such high risk for breaking. Okay, this is something that, I don't know if you have in your notes, but I included. I'll have, maybe Sunny, you can post these slides, because I added this just today, just because it kind of combines everything at once. Sure. And puts it on my table. Sure. I thought that it was kind of a nice thing. Okay, but so treatment really depends on the severity of symptoms, right? If you have a calcium level that's not quite as high, the treatment is not going to be the same. But when you get to that 13.5 number, your treatment is going to escalate, of course. And really the goal here is we want to improve the patient's renal function. Calcium and extensive amounts of calcium is going to start bogging down the renal system, just like with tumor lysis syndrome, right? And we have to improve renal function with lots of fluids. We're going to be watching their mental status, and we're trying to, again, resolve the underlying malignancy. Okay, with mild hypercalcemia, a lot of these are non-pharmacological. So these patients will have sometimes chemotherapy or anti-neoplastic therapy to try to treat that underlying disorder, which is a lot of times their cancer, or sometimes it's the bone met. They might have radiation to try to treat that bone met. Oral hydration is important for these patients to try to flush out the kidneys, so 1 to 2 liters a day. Weight-bearing exercises is actually very important to remember. So again, with mobility and with weight-bearing exercise, the body brings in more calcium into the bone to strengthen it. And that's going to pull calcium out of the vascular space, and the levels aren't going to be quite as high. Everything else is pretty self-explanatory. Sorry, I'm trying to get through the rest of our slides in time. So tell me to slow down if I need to. With moderate hypercalcemia, 12 to 13.5, a lot of times these patients are put on telemetry because of all of those cardiac arrhythmias that are a potential risk. IV fluids are going to be bumped up. It's not going to be oral hydration anymore. We're not going to give them styrofoam cups of water. Now we're going to actually be putting in an IV and giving lots of fluid. 4 to 6 liters of NS a day for ONS. We're also going to be giving biphosphonates, bisphosphonates. You've never given those? A lot. Is that what you said?
All day long.
What do those do for a patient?
They should put the calcium back into the.
Yeah, it allows the calcium to be drawn back into the bone, basically. And it slows bone loss, right? So we know that there's, the osteoclast and the osteoblast, and that's a normal function in the bone where osteoblasts are constantly breaking down bone, and then osteoclasts are trying to repair it. And that's just a normal function in the body. When we give a patient bisphosphonates, like Zometa is probably the one I've seen most frequently, would you guys agree? And that's this. These patients are going to be having slower bone loss or slower bone destruction. A lot of these patients are breast cancer patients or patients with bone mets. Okay, or Iridia or Pimidronate is something else that we've given even inpatient. You'll see that too. Again, treat underlying malignancy. You can't get that across enough, obviously. With severe hypercalcemia, this is a level of greater than 13.5. Again, these patients might have to get chemotherapy to get this under control because that's treating the underlying disorder. And it's the best long-term solution for a patient, right? But we're not going to give chemo to a patient that has those crazy cardiac arrhythmias. We're going to have to figure out what to do in the temporary space, right? So bisphosphonates are also important here as well, but sometimes as a last resort, these patients will go on dialysis. And it's a similar reason to tumor lysis syndrome, right? We're going to have to just pull it off because the kidneys are being bogged down and everything else is happening in the body. We can't just give them chemo and wait for the effect to happen. We're going to have to put them on dialysis and pull off the calcium, right? Severe volume overload, renal failure, etc. Or sometimes just refractory to medical treatment. Sometimes what we're doing is just not working, so the only thing we can do is like physically pull it off of the patient's body. Okay. Nursing interventions here.
Yes. Sorry,
Yes.
I know
Oh,
you're
yeah.
trying to fly through, but earlier you told us to remember calcium needs greater than 10.5, and I did not write down other than that, and then all other numbers with 13.5. So 10.5, what do I need to write
Is
down?
when we consider that to be a high number. But the onc-emergency level for severe hypercalcemia is 13.5. That's a good
Thank you,
question.
sorry, I just
You're totally fine.
write it all out, and I wasn't sure if
You're
I
good.
was there, and
Yeah, you're good. So 10.5 would be like when it's just high, right?
Okay.
But then 13.5 is when it's severe, and that's when it's a true onc-emergency.
Okay.
Yeah, good question. So nursing interventions are all going to relate to maximizing safety. These are things we should be doing all the time for patients, but they should have their call light, they should have their bed rails up, bed in low position. We would never want them to fall because of their neurological status being down, right? So we've got neuro checks, transfer devices. Patients are a lot of times on telemetry with high calcium levels and non-seizure precautions. Okay? And they should have a fall wristband. All right. We're monitoring daily weight again because we're looking at fluid status a lot of times. Strict I's and O's because we're pumping these patients full of fluid too, right? We have to make sure that they're not having leaky vessels. Oh, we go left. Leaky vessels, and we're losing that to the interstitial space. We want to maintain our urine output between 100 and 150 mils an hour. And that's high, it seems, kind of. I feel like that's kind of high. I don't know if I pee that much in a day. I don't know if you say that before. But anyway, we should be pumping fluid through them and seeing them urinate that out because that means that the kidneys are working and they're flushed through, right? If they're not urinating well, we know that there's some sort of backup. And we should be watching for fluid overload, right? So jugular venous distension, we might see edema throughout the body, we might feel and hear crackles in the lungs, shortness of breath, all those things. Close. Okay, we're to our last section. We're actually not too bad on time. For 15 more minutes, right, Sunny? Okay. Woo. Good job, Ruby. Okay, this is the last one. I'm so glad we have some infusion nurses here because they know all about this, right, ladies? Hypersensitivity and anaphylaxis is a true oncologic emergency. And this is something that our patients are at high risk for because we give crazy drugs all the time. We give phase 1 clinical trials. We give chemotherapy that causes innate reactions, right? We give blood transfusions that cause reactions. So we have to be aware of this as an oncologic emergency. And the definitions are a little different between hypersensitivity and anaphylaxis, right? So these are some of the definitions we found for hypersensitivity. It's an undesirable reaction. I think that's kind of funny. It's definitely undesirable, right? Undesirable reaction produced by normal immune system in response to that exposure of an antigen or an allergen, right? So the body freaks out a little bit because what we're introducing to the body is foreign and it's not recognized. I mean, the body's not going to recognize this phase 1 clinical trial or this chemotherapy, and it's going to mount a response, which is normal, right? But we have to deal with that. It may refer to allergic reactions, or this is the big part, infusion-related reactions. That's typically what we'll see with our oncology patients, and it can be linked to certain types of antineoplastic therapy. Very common sense. But with anaphylaxis, this is where it can get a lot more serious. This can be a reaction that potentiates a life-threatening emergency. And you ever have a patient have anaphylaxis? Is that scary or what?
Very.
Very scary. I mean, we have anaphylaxis kits like ready to go, right? Don't you guys have them like in your pods?
We have them that we bring in.
Yeah, so they're very well educated on which drugs have the potential risk, right? And which patients have had history of reaction and all these other things. Those are important to remember. It may be generalized or systemic hypersensitivity. So this is just basically the emergency piece of hypersensitivity, okay? So there are different types of hypersensitivity. This stuff is over my head. It's probably over your head. I don't know that we need to know this, but it's a good FYI that helps us explain why patients react differently and certain drugs cause different reactions. So you have type 1, which is an immediate hypersensitivity reaction type. This is most common with our antineoplastic, so this is one you'll see a lot with our patients. And it's IgE mediated. What's interesting is that further exposure to that drug, to the same antigen, results in mast cell degranulation and inflammatory response. So sometimes the more they're exposed to a drug, the higher risk for reaction. Right, Sunhee, infusion educator, thank you for that confirmation. So type 2 is our cytotoxic hypersensitivity reactions, okay? This is IgG or IgM mediated. Interesting fact. This can take just a few minutes to react or to cause a reaction, or it can take up to hours, right? So it's variable in patients, and it involves the complement pathway being activated, right? Type 3, which is our immune complex hypersensitivity, is where this could take anywhere from 3 to 10 hours after exposure. Again, variable, right? This one's harder for me to understand. The response may be general or may involve individual organs, including the skin, the kidneys, lungs, so it's very different with everything. Damage is caused by platelets and neutrophils in these patients, and it again involves IgG and IgM. Okay? The last one is our delayed hypersensitivity reaction. And this is T-cell mediated. So there's no antibodies involved here. It's not IgG or IgE. The response typically takes 48 to 72 hours. And examples for this kind of reaction are like penicillin. Patients might have reaction to something like that. TB, contact dermatitis. Nothing oncology specific. But basically it's a more delayed response. So 48 to 72 hours. Okay. Which is kind of crazy, like 3 days later, they have to come back to you, a drug you gave them, like, that's a little harder.
The CAR T cell now is that one, right?
That what?
The CAR T cell?
Oh, yeah, T-cell mediated. Yeah, good job, Savannah. Don't fall out of your chair. I got so excited about her response. All right, this is another table that should be included in your PowerPoint because I didn't add anything today. But that just goes over the different type of hypersensitive reactions and the components, right? Type 1, 2, 3, 4. Nothing that you would ever need to memorize, but kind of interesting and good to look through. Severe symptoms of hypersensitivity indicate that anaphylaxis. So again, that is the piece that we consider life emergent, right? And sometimes we can see even cytokine release syndrome. Something Silvana mentioned is our CAR T cell patients, right? So our BMT nurses have been very educated on cytokine release syndrome. Would you agree? And Irina, right? Anyone else BMT? No. Just you two. Yeah. Yeah, you and Irina. So basically, we can have this release of cytokines from targeted cells that cause a lot of different symptoms, but basically it's fever, chills, low blood pressure, short of breath, scratchy throat, which can look very similar to anaphylaxis, but sometimes it's specifically cytokine release syndrome. I don't know that we would ever know just from looking at a patient, but there is a difference. There are certain drugs that can put you at risk for a reaction more than others. Our infusion nurses can attest to that, right? And inpatient nurses, outpatient, we all know this. Platinums or platinols, so carboplatin, oxaliplatin, those are two to remember. Do they get that drug list, Sunhee, that has like all the table that has all the different drugs and they still get that, right? As part of the study guide
From you?
The one that we had on the website like a while ago.
Was it on the website?
Yeah,
then they will get.
Okay, so look at that study guide that is given to you guys through the Canvas page, because that has a lot of this information. It goes through specific drugs and what to remember for those drugs. So we won't go over the details, but some of these are kind of interesting. With taxanes, you're gonna have a more severe reaction with the first or second dose, okay? So sometimes you'll see what's known as a desensitization protocol, where you have to basically like build them up to being tolerable to it. Is that how you would explain it? I don't know how to explain that. What other ones are interesting?
That carbo a lot,
Do they?
the desensitizations.
Carboplatin, so that goes along with your platinols, right? Yeah.
Is that been delayed? Like after?
Carboplatin with a delayed response? I think it can be, yeah. Yeah. Etoposide is interesting because it commonly occurs after multiple doses, so that the more that they're exposed to something like an epipodophylotoxin, I love saying that word, it's so fun. When they're more exposed, the more doses that they receive, the higher risk they are for a reaction. Another, oh no, that's not the same list. Anyway, those are interesting to look at. Also, L-asparaginase, they'll do intradermal testing. I don't know if we still do that here. I know we used to. On inpatient, they give that for BMT patients. They would do like a little spot on their skin before they ever got an infusion to see how the patient reacted to it. I haven't seen that done in a long time. That's something that can be done prior to administration, just to make sure that you know what risk they're at. But again, like I mentioned earlier, we have to be aware of the patient's history with reactions, because again, that's important to know for what's going to potentially happen when we give them the drug again. We have to know where they're at in their cycle, right? Is this a drug that gets higher risk for reaction as you go along, or is it more risk at the beginning in the first dose? IV administration is obviously a higher risk than giving someone like a sub-Q injection or an oral chemotherapy. So that's important to know. Patients that have a short interval between exposures or administrations, that puts them at higher risk. So that's someone who's getting like, you know, Q3 hour, Q4 hour chemo, or maybe like every day versus someone who gets it every 3 weeks. It's a little different. Some patients just have, you know, issues with allergies to something like latex, and that can even put them into that hypersensitivity picture without anaphylaxis. Blood products also have the potential for causing this type of reaction, and even foods. I'm allergic to a ton of foods. So I have to be careful. I carry an EpiPen with me everywhere I go because I have a lot of food allergies. And I could become anaphylactic from eating a walnut. So it can happen from foods too. All right, so this is just a timeline. This helps us look and see at symptoms and when they would occur on the spectrum. So basically, with hypersensitivity, you might start seeing something as simple as like an itch on the face. I remember this can happen with stem cell infusion as well, and I remember my first time a patient reacted to their stem cells, and all I knew from the beginning was that they had this little itch on their cheek. They're like, I just have an itch right here. I'm like, it's weird. And they're just like, oh yeah, it's really itchy, and now my whole cheek is itchy. And then like within 5 minutes, she was very short of breath. And we were stopping the infusion and giving steroids and having all sorts of interventions. So it could be facial flushing. It could be a tickle in their throat. What else do you guys see?
Palms.
Itching on the palms of their hands, sometimes or soles of their feet. Sometimes patients do get nauseous, or they might just have like dizziness, chest tightness. Is that what you're saying? Yeah. Yeah.
Back pain.
Oh, back pain, that's a good one. Yeah. Has anyone ever had a patient say, I just don't feel good. I don't know what's wrong, but I have like this feeling of impending doom. That's a scary thing, right? I've had a patient say that to me, and I'm like, okay, I don't know what that's all about, but we're gonna stop the infusion and we're gonna figure this out, because patients do sometimes get anxiety as a symptom. Or a side effect, and they might have that feeling of impending doom. They just can't put their finger on it. They don't know what's wrong, but they can tell something's wrong, and we should definitely listen to them. And they start to get really restless. I've had patients say like, oh, I just gotta get up and walk around. Like, I don't know why, but I'm just feeling really restless. I've gotta get up and move. You guys seen that? Okay. So when we start getting down to the anaphylaxis picture, we're gonna see much more severe side effects. So shortness of breath to the point of their airway closing off, right? Chest tightness, edema here, right? So again, airway closing off, tongue can swell, lips can swell. You might start seeing very, very severe vital sign alterations, so low blood pressure, high heart rate, that's sepsis picture basically. Some patients will spike a fever, but ultimately, if you don't treat this, it will lead to death. It will lead to cardiovascular collapse and death. So it's a very, very scary thing for our patients. We have to watch this very closely. Pre-treatment is important, right? We have to sometimes pre-medicate our patients, especially those patients that are getting specific chemotherapies or specific infusions, or patients that have a high risk or history of reaction. So we give steroids a lot of times to these patients, mixed with sometimes Benadryl, right? So you might give a steroid and a Benadryl and a Tylenol and something like a ranitidine, right? So an H2 blocker and an H1 blocker. And these are very common in pre-treatment. With managing anaphylaxis or hypersensitivity, a lot of things are done, but the first thing we have to do is stop the infusion. Very important to remember. Number one, before you do anything else, you stop your infusion, right? You're gonna probably start administering other things like IV fluids, probably more steroids, all sorts of things. But you're gonna have emergency equipment at the bedside. Like she was saying, I don't remember your name, Sally. Sally was saying that for certain patients and certain drug regimens, they just have their emergency kit at the bedside because that's such a high risk, and they know that the patient's at risk. They're just gonna have it there ready to go. That's awesome, right? But how important is it to understand which patients are at risk and what their history is like? Because then we can have that type of equipment and those medications ready to go. I remember with certain patients on BMT, I would just have like extra steroid and extra everything else in my pocket after I already gave the pre-meds because I knew for a fact that they were going to react, and I just had it ready, right? We're going to be taking vital signs for the patient more frequently than we were before, maintaining their airway, giving supplemental oxygen, and then obviously notifying the provider because the patient might have to completely stop the infusion and not have it started up again, or we might have to wait quite a while before we start the infusion again. Depends. Okay, questions on that? Just remember first thing, stop. Okay, with pharmacologic management, like I said, we might give more steroids. Albuterol is going to help open that airway, right? Vasodilation in the bronchial airways. H1 blockers and H2 blockers can be given to help as well. And then sometimes you might even have to give epinephrine. Like I said, I bring my EpiPen with me everywhere I go because that's a risk for me. And an epi dose is in your emergency kit, correct? Yes. So epi, think adrenaline, right? So we've got that fight or flight response, and that's what's happening in the body when we give epinephrine. All right. Take home from this section is that we have to be aware of the patients that are at risk. So knowing the patients that have history of reaction, knowing the drugs that cause this, or the infusions that cause this, be aware of patients' allergies. Something like latex could be a severe thing for them, and that might cause them problems. And always obtain baseline vital signs for our patients because we have to know what their trends are looking like. And use your magnifying glasses that you all have in your pockets. Okay, question on a lot of content. I know this class is like packed full of information.